Hello and welcome back to the Deep Dive.
Hello.
Today we are shifting gears pretty significantly. We aren't just exploring a topic for general interest.
No, not at all.
We are simulating a high-stakes, a pressure cooker environment.
That's a good way to put it.
We're trying to get into the mindset of an exam candidate.
Mm-hmm.
Specifically, a resident who's sitting across from a senior MD anesthesia faculty member getting ready for the Gujarat University MD exams.
That is right. And the stakes couldn't be higher because the topic is the absolute bedrock of our specialty. Basic life support and advanced life support.
BLS and ALS. And, it's so easy to just dismiss this as first-year stuff, right?
Oh, absolutely. Everyone thinks they know it.
You do a BLS course, day one of residency, you get the card, you move on.
Mm.
But when we actually dug into the source material for this, and we're talking everything, Miller's Anesthesia, 10th edition, Morgan and Mikhail, the latest ICU protocols, and we even looked at trends from the DNB question bank, we realized that basic is a massive misnomer here.
Completely. I mean, if you walk into a Viva or a theory exam with a layperson's understanding of CPR, you'll fail. It's that simple.
Right.
The learner profile we are targeting today is the anesthesiologist. We are the resuscitation experts. The examiner expects you to know not just how to push on a chest, but the hemodynamics of why you're doing it, the pharmacology of the drugs, and the exact algorithm to manage a chaotic code blue.
That's the hook we found in the notes. This idea that resuscitation is the anesthesiologist's home turf.
It is. I mean, think about the skill set. Airway management, that's us.
Of course.
Hemodynamic support, that's us. Pharmacology under pressure, that's us. When a code happens anywhere in the hospital, who do they call?
They look for the anesthesiologist.
Everyone looks for the anesthesiologist.
Yeah.
So this deep dive is really about bridging that gap between knowing CPR and mastering resuscitation for a 20-mark theory answer, or, a really grueling VIBA station.
We have a massive stack of notes here, so let's try and structure this logically. We're going to move from principles and exam framing, then through the physiology of BLS, deep into the ALS algorithms, and then we'll finish with special situations and post-resuscitation care.
Sounds like a plan.
So let's start with Part A, Introduction and Exam Framing.
Let's get into it.
Okay, start with the absolute basics, the definition. It sounds trivial, but I know in Aviva, precision is everything. If an examiner asks, define cardiac arrest, what is the exact bulletproof answer you need to give?
You have to be crisp. You don't want to waffle here at all. The formal definition is cardiac arrest is the cessation of all cardiac mechanical activity.
Okay.
But clinically, and this is what they're really looking for, it is confirmed by a triad. Unresponsiveness, the absence of a detectable pulse, and apnea or agonal respiration.
I want to pause on that last one, agonal respiration. Looking at the notes, this seems to be a major trap.
It is the classic trap. Agonal breathing, those slow, gasping, irregular breaths, it is a sign of cardiac arrest.
So it's not breathing.
It is not a sign of life. It's a brainstem reflex to severe hypoxia. The trap is that a nervous candidate sees the patient gasping and they hesitate. They think, oh, they're breathing. I shouldn't start compressions.
Right, you second guess yourself.
And if you say that in a Viva, or if you demonstrate that hesitation in an OSCE, you fail the station. Instantly. Gasping equals arrest. You start CPR.
Okay, that's crystal clear. Gasping is arrest.
Yeah.
Now, moving to the chain of survival. Miller and the ARC guidelines make a huge deal about this concept. How do we structure that for, say, a theory answer?
You have to visualize it as linked actions. It's a chain for a reason. If one link breaks, the patient dies. For an adult, you need to list 5 specific links.
Okay, what's number 1?
1, immediate recognition and activation. You have to realize the patient has arrested and you have to call for help. Shout, activate the code.
Makes sense.
2, early CPR. And the emphasis here, and we'll come back to this again and again, is heavy on chest compressions.
Right.
3, rapid defibrillation. For VF, this is the single biggest predictor of survival. It's all about the shock.
Okay.
4, effective advanced life support. So that's where the drugs and the advanced airways come in.
And 5.
And 5, integrated post-cardiac arrest care.
So the job isn't done just because you get a pulse back.
Exactly. But here is the nuance that distinguishes a specialist from a generalist, something that will get you extra marks. The pediatric chain of survival is different.
So?
It starts with a different first link. It starts with prevention.
Prevention. Why the shift?
It's all about the pathophysiology. Adults usually have primary cardiac events, a sudden arrhythmia like VF. Their heart just goes haywire.
An electrical problem.
An electrical problem, exactly. Kids are different. They usually have respiratory or asphyxial arrests that progress to a cardiac arrest. So if you can prevent the choking, the drowning, the severe asthma attack,
You prevent the respiratory failure.
and you prevent the arrest. An examiner might ask, why is the pediatric chain different? Your answer is, because the etiology is typically respiratory, not primary cardiac.
That's a fantastic distinction, a real high-yield point. Now let's talk about our role in all this. Why does Miller explicitly call the anesthesiologist the subject matter expert?
Well, because we do this every single day, just in a controlled setting. Think about it. General anesthesia is essentially a controlled coma where we support the airway and the circulation.
Right, we're managing it proactively.
So when we move to a code blue, we are just applying those same skills in an uncontrolled setting. We manage the non-cutting care. We understand the drugs adrenaline, amiodarone, better than the surgeon, better than the internist. We are the natural team leaders in that chaos.
And looking at the DNB question bank, this theoretical knowledge is tested really heavily. We're seeing these long questions, 10 to 20 marks. Things like, describe the ALS algorithm for VF.
Yep.
Or write a short note on high-quality CPR.
You cannot bluff these. You absolutely need to know the flowchart's cold. There's no faking it.
All right, that sets the stage perfectly. Let's move into Part B, basic life support. And again, let's keep this laser focused on what's high yield for the exam. What is the physiological aim of BLS?
The definition is right there in the name. Basic life support. So we are maintaining airway, breathing, and circulation without any advanced equipment.
Just your hands and maybe a mask.
Exactly. But the physiological goal is very specific. We are generating just enough perfusion pressure to keep the heart and the brain viable. We aren't fixing the problem.
You're just buying time.
We're buying time. We are bridging the gap until we can defibrillate or give drugs or find and fix the underlying cause. We're preventing irreversible ischemic damage.
Got it. Okay, now the algorithm itself, it used to be ABC, airway, breathing, circulation. Now for years it's been CAB. Circulation first. Why? This seems like a favorite question to test the understanding of physiology.
It is absolutely essential to understand this. The shift to CAB is based entirely on the physiology of the blood at the moment of arrest. In the first few minutes of a sudden cardiac arrest, the blood is fully oxygenated.
Because the person was breathing right up until they collapsed.
Exactly. So the problem isn't a lack of oxygen content in the blood. The problem is flow. The blood isn't moving.
So stopping to do a head tilt chin lift is just wasting time.
It wastes critical seconds. Compressions generate perfusion pressure. Every single second you spend fumbling with the airway is a second where the coronary perfusion pressure is zero. The brain isn't getting any blood. You need to move that already oxygenated blood to the brain immediately. Hence, circulation first.
That makes perfect sense.
Okay.
Let's walk through the sequence. Imagine we're in an OSCE station. The mannequin is on the floor. Step 1.
Scene safety. Always. You cannot save the patient if you become a victim yourself. Look around. Check for electrical wires, fire, traffic, whatever.
Okay, scene is safe. Step 2.
Check responsiveness. You tap the shoulders firmly. You shout, "Are you okay? Can you hear me?"
No response. Step 3.
Assessment. And this must be simultaneous. This is an upgrade in the guidelines. You don't look, then feel for a pulse. You are looking for breathing, or, remember, gasping and checking the carotid pulse at the same time.
And there's a really strict timing constraint on that, isn't there?
No more than 10 seconds.
Right.
This is a hard limit. In an OSCE, they will have a stopwatch on you. If you are fumbling around the neck for 15 seconds, you fail.
What if I'm not sure? What if I think I might feel a little flutter, but I don't know for sure?
Then you assume it's an arrest. The guidelines are very clear on this. It is far safer to do chest compressions on a heart that is beating very weakly than to do nothing on a heart that has stopped. When in doubt, start CPR.
Okay. Step 4 is activation, shout for help, call for the AED. Step 5 is circulation start compressions. And this brings us to probably the most important concept in the entire discussion, high-quality CPR.
This is exam gold. Seriously, if you write nothing else in your theory paper, write this section well. You can know every drug dose in the book, but if your CPR mechanics are trash, the patient dies. The mantra is simple. Push hard, push fast.
Let's break down the metrics from Miller. Speed first, push fast.
The rate is 100 to 120 compressions per minute.
Why that specific window? I mean, why not 150? Wouldn't faster be better?
It's a great question, and it's a common misconception. It's a hemodynamic sweet spot. If you go below 100, you don't generate enough cardiac output per minute. Simple as that.
Right.
But if you go above 120, you run into the problem of diastolic filling time. The heart is a pump. It needs time to fill with blood before you squeeze it again. If you're going at 140, you were just fluttering the ventricles. They never have time to fill, so you never pump anything out. You're just working hard for no result.
So 100 120 allows for both adequate filling and ejection. Okay. Now, depth. Push hard.
5 to 6 centimeters in adults. At least 5 centimeters, but not more than 6 centimeters.
Why is that so specific?
You need to physically squeeze the heart between the sternum and the spine. Less than 5 centimeters, you aren't squeezing hard enough to generate flow. More than 6 centimeters, and you start increasing the risk of trauma rib fractures, liver lacerations, without any added hemodynamic benefit.
Okay, so rate and depth. What's the third metric?
Recoil. And this is the one where people get lazy, especially when they get tired. You must allow complete chest recoil. Let the chest come all the way back up to its normal position.
Why is that so critical physiologically?
Think of the heart as a suction cup. During the recoil phase, which is diastole, the negative pressure inside the chest actually pulls venous blood back into the heart.
That sucks the blood back in.
It sucks it back in. If you lean on the chest, you keep the intrathoracic pressure positive. You are essentially choking off the venous return. If blood can't get back into the heart, you have nothing to pump out on the next compression. Leaning is lethal.
That's a fantastic visual. And the final piece of high-quality CPR, interruptions.
Minimize them at all costs. We talk about the compression fraction. What percentage of the total code time are you actually pushing on the chest? The goal is to get that as high as possible, ideally over 80%.
Because every time you stop, the pressure just drops to zero.
It drops to zero immediately, and it doesn't just pop back up when you start again.
Or you have to build it back up.
Exactly. It takes several compressions to build that coronary perfusion pressure, the CPP, back up to a therapeutic level. So frequent pauses mean you are constantly starting from zero. You never get the perfusion pressure high enough to actually perfuse the brain or the heart muscle itself.
Now, Miller and Morgan both discuss the theories of blood flow, the thoracic pump versus the cardiac pump. For a postgraduate theory exam, we probably need to mention these, right?
Definitely. It shows that extra layer of expert understanding. The cardiac pump theory is the simple one. You are directly squashing the heart between the sternum and the spine, squeezing it like a sponge.
Makes sense.
The thoracic pump theory is a bit more complex. It says that your compression raises the overall pressure in the entire chest cavity, the whole thorax.
Not just the heart.
Not just the heart. This generalized pressure increase pushes blood out of the aorta. Then, when you release, the aortic valve closes and prevents backflow. In reality, it's likely a mix of both mechanisms, and it probably varies depending on the patient's chest size and the technique being used.
Good to know.
Oh.
Okay, let's move on to airway and breathing in BLS. We've started our high-quality compressions. When do we actually give the breaths?
In BLS, it is a strict 30-to-2 ratio, 30 compressions, then you pause briefly, give 2 breaths, and get straight back on the chest.
Is there any situation where that changes for the BLS provider?
For a layperson or a single rescuer, no, always 30.2. But for us, as healthcare providers, there's a nuance in pediatrics. If you have 2 rescuers doing CPR on a child or an infant, the ratio shifts to 15.2.
And that's because of the higher metabolic demand we mentioned earlier. Kids are more likely to have a hypoxic arrest.
Correct. Children have higher oxygen consumption rates and are more likely to be hypoxic to begin with. They benefit from more frequent ventilations.
Now, here is a point from Miller that I think is absolutely crucial for both the exam and for real life. The danger of hyperventilation.
This is massive. In the heat of the moment, adrenaline is pumping, people get anxious, and they tend to bag the patient like they are pumping up a bicycle tire fast and hard. This is incredibly dangerous.
Explain the physiology. Why does too much air actually kill the patient?
It comes back to that intrathoracic pressure we were just talking about. Positive pressure ventilation, especially aggressive ventilation, dramatically increases the pressure inside the chest. We just said that we rely on negative pressure during recoil to pull blood back into the heart. If you are constantly blasting the chest with high pressure from the bag, you create a continuous positive pressure that collapses the vena cava.
So you're fighting against yourself.
You're completely fighting your own compressions. You reduce venous return, which means you reduce cardiac output. You can literally ventilate a patient to death during CPR.
So the technique is gentle breaths, just enough to see the chest rise.
Precisely. Each breath given over 1 second. Don't force it. Just a gentle squeeze until you see that chest begin to move. That's all you need.
Let's wrap up the BLS section with the AED, the automated external defibrillator.
The algorithm here is designed to be foolproof. You turn it on, it will talk to you. You attach the pads to the patient's bare chest. The standard position is anterior lateral.
One below the right clavicle, one on the left mid-axillary line.
Correct. Then you plug them in. The machine will tell you, analyzing rhythm, do not touch the patient. You clear everyone, and then it will either say shock advised or no shock advised.
But here's the specific Viva trap. Let's say the machine says shock delivered. What is your hand doing in the very next second?
It is going straight back to the center of the chest to resume compressions.
You do not check for a pulse.
Never. You resume chest compressions immediately. No hesitation.
Why? Why not check if the shock worked?
Because even if the shock was successful and you terminated the VF, the heart is stunned. It might be electrically organized, but it's mechanically very weak. It isn't pumping effectively yet.
It needs help.
It needs a minute or two of mechanical support, or compressions, to get the blood flow moving again and perfuse its own coronary arteries. If you stop to check for a pulse, you waste that critical support time. The rule is you only check the rhythm again after 2 full minutes of CPR.
Perfect. That
Yeah.
feels like a really solid wrap-up of BLS. High-quality compressions, minimal interruptions, CAB sequence, and immediate CPR after a shock.
That's the core of it.
Okay, so now let's graduate. Let's move to Part C, Advanced Life Support.
This is where we, as anesthesiologists, really earn our money.
So ALS is the integration of everything we just discussed, but now with advanced airways, with pharmacology, and with differential diagnosis.
And the anesthesiologist is almost always the team leader here. You are running the code. You need to be calm, you need to be directive, and you need to be thinking 2 or 3 steps ahead of everyone else.
Let's visualize the ALS algorithm.
Ah.
We've all seen the flowchart in the textbooks. The monitor pads are on the patient. What is the very first binary decision you have to make?
You look at the screen and you have to categorize the rhythm into one of 2 boxes. Is it shockable or is it non-shockable? The entire management pathway diverges right there at that single decision point.
Okay. Let's go down the left arm of the algorithm first, the shockable rhythms. What are we looking at on the monitor?
You're looking for ventricular fibrillation VF, which is just chaotic squiggles, or you're looking for pulseless ventricular tachycardia PVT, which is a very fast, wide, regular rhythm, but the patient has no pulse.
So the heart has electrical energy, it's just quivering or firing too fast, but there's no coordinated pump.
Precisely. It's disorganized. And the only treatment for that disorganization is electricity. A hard reset.
Walk us through the sequence then. We've identified VF, we've charged the defibrillator, shock delivered, then what?
Shock. Then immediately, without a single pause, CPR for 2 minutes.
Okay, the 2-minute cycle is up. What's next?
Brief pause or rhythm check. If it's still VF or PVT, you shock again.
And after that, second shock.
Immediately CPR for another 2 minutes. And here is where we start introducing pharmacology. After that second shock, while the team is doing compressions, that's when you give the first dose of adrenaline.
Okay, so the drug goes in during the compressions, then what?
2 minutes of CPR pass. You do another rhythm check. If it's still refractory VF, you shock a 3rd time, back on the chest for CPR. And after this 3rd shock is your window to give an antiarrhythmic. Amiodarone. So the rhythm is shock CPR adrenaline, shock CPR amiodarone.
Got it. That's a very clear sequence.
Yeah.
Now let's switch to the other side of the algorithm. The right arm, the non-shockable rhythms.
This is a systolia flatline, or pulseless electrical activity PEA.
What's PEA again?
PEA is where you see an organized-looking rhythm on the monitor. It could even look like a normal sinus rhythm, but when you check the patient, there is no pulse. The electricity is there, but the mechanics are gone.
And the big question, can we shock these?
Absolutely not. And I have seen students fail a station for suggesting a shock on asystole. You cannot shock a heart that has no electrical activity. There's nothing to reset.
So what is the treatment then?
It's just 2 things, high-quality CPR and adrenaline. And with the adrenaline, you give it as soon as possible. You don't wait for a second cycle like you do in the shockable arm. You get IV access and you push adrenaline ASAP.
Let's deep dive into the physics of defibrillation for a moment. Miller specifies energy settings. Can you talk about that?
Sure. Most modern defibrillators are biphasic. This means the current travels in 2 directions, from one pad to the other and then back again. This is much more efficient and causes less myocardial damage.
And the dose?
The standard dose is 120 to 200 joules, but really you should use the manufacturer's recommendation. If you don't know the machine's specific setting, you just dial it to the maximum energy. You can't go wrong with that.
And what about the older monophasic machines you might still see?
They require a much higher energy because the current only flows in one direction. For monophasic, it's a fixed dose of 360 joules for everything.
Safety is the other big exam point here, I imagine.
Huge. You have to be loud and clear with the clear drill. I'm clear, you're clear, everybody's clear. And you have to physically, visually sweep the bed area. Make sure no one is touching the patient, the bed frame, anything connected to them.
Right.
And for the exam, it's always good to mention that self-adhesive pads are now preferred over the old-fashioned handheld paddles. They allow for hands-free operation, which is safer, and you can monitor the rhythm continuously through them.
Good tip. Let's talk about airway management in ALS. We're anesthesiologists. We love to intubate. So in a code, do we just jump in and intubate immediately?
Not necessarily, and this is where expert judgment comes in. The absolute priority is oxygenation and ventilation, not necessarily intubation. If you can get a good seal and effectively ventilate the patient with a bag mask, that is perfectly acceptable in the early stages.
So don't stop good compressions for an early, difficult intubation attempt.
Absolutely not. But that being said, eventually we do want a secure, definitive airway. An endotracheal tube, an ETT, is the gold standard. A supraglottic airway like an iGel or an LMA is also a very good option.
And what's the rule on the timing for the intubation attempt itself?
If you are going to intubate, you must be slick. You do not interrupt compressions for more than 10 seconds.
10 seconds.
That's it. Ideally, a really skilled operator can intubate during the upstroke of compressions without any pause at all. But if you can't get the tube in 10 seconds, you back out, you bag the patient for another cycle, and you try again later. The tube can wait. The brain can't.
Now, once that advanced airway is in, the entire mechanics of CPR change. This feels like a vital exam detail.
It is. Once the ETT or the LMA is secured, you stop the 30.2 cycles. You move to continuous compressions. The person on the chest just keeps pumping at 100, 120 beats per minute without ever stopping.
And the breathing?
The person on the airway gives breaths asynchronously, one gentle breath every 6 seconds. That works out to 10 breaths per minute.
And how do we confirm that the 2 is in the right place?
Waveform capnography. It is the gold standard. Not listening to the chest, not seeing mist in the tube. You need to see that characteristic square wave trace on the monitor. That's your proof.
But capnography isn't just for confirming tube placement, is it? It also tells us about the quality of our CPR.
A brilliant point. In a low-flow state like cardiac arrest, the end-tidal CO2, the ETCO2, is a direct correlate of cardiac output. If your ETCO2 value is less than 10 mmHg, your compressions are garbage. You're not generating enough flow. You need to tell the compressor to push harder or faster, or you need to swap them out.
And on the flip side, what if that number suddenly shoots up?
If it's been hovering around 15 and it suddenly spikes to 40 or 45 mmHg, that is the single earliest sign of ROSC return of spontaneous circulation.
Before you can even feel a pulse.
Often before you can feel a pulse. It means the heart has started pumping blood effectively to the lungs, and that blood is delivering CO2 to be exhaled. If you see that jump, you complete the current 2-minute cycle of CPR, and then you check for a pulse.
Fantastic. Okay, let's move to pharmacology. Section 11 of the outline. Adrenaline is the backbone here.
Adrenaline, or epinephrine. The dose is 1 milligram given as an IV push.
Why do we give it? What's the receptor mechanism we're targeting?
It's a common misconception that we give it for its beta effects to kickstart the heart. That's not the main reason. We give it for its potent alpha-1 adrenergic effects.
So vasoconstriction.
Pure vasoconstriction. By clamping down on all the peripheral blood vessels, we dramatically increase the systemic vascular resistance, or SVR. This, in turn, raises the diastolic pressure in the aorta.
Which is what drives blood into the coronary arteries.
Yeah. Exactly. The heart muscle gets its blood supply during diastole. By jacking up the aortic diastolic pressure with adrenaline, we are forcing blood into the coronaries. We are sacrificing perfusion to the fingers and toes to feed the heart and the brain.
Makes sense. And amiodarone, what's its role?
It's a class 3 antiarrhythmic. It basically works by prolonging the action potential and stabilizing the cardiac membrane. We use it for refractory VF or PVT-SO, cases that haven't responded to the first few shocks and adrenaline.
On the dose.
The first dose is a 300 milligram bolus. If VF persists, you can give a second, smaller dose of 150 milligrams.
What if your hospital doesn't have amiodarone for some reason?
Lidocaine is the accepted alternative.
And magnesium. I feel like on TV medical dramas, they are always shouting for magnesium.
Yeah, that's TV. Magnesium is only indicated for one specific rhythm, torsades de pointe, which is a specific type of polymorphic VT. It is not a routine drug for a generic cardiac arrest.
Okay, let's talk routes of administration. 4 is obviously the first choice. What if you can't get a line? The patient's veins are all collapsed.
The next best choice, and it's an excellent choice, is intraosseous, or IO.
Drilling into the bone.
Yep. You use a special drill to place a needle into the bone marrow cavity, usually in the proximal tibia or the head of the humerus. It's incredibly fast, the line doesn't collapse, and the pharmacokinetics of drugs given IO are almost identical to central venous access.
So it's as good as a central line in a coat.
For all intents and purposes, yes.
What about down the ET tube, the endotracheal route? Is that still a thing?
It is a last resort. We used to teach it more, but we now know absorption is erratic and unreliable. There's a mnemonic, ONAVE, for the drugs you can give. Oxygen, naloxone, atropine, Ventolin, epinephrine.
Okay.
But you need to give 2 to 2.5 times the normal IV dose, and you have to dilute it in saline. Honestly, in this day and age, if you can get an IO in, which you almost always can, you should do that instead.
Okay, that covers the active fight perfectly. Now let's imagine we win. The capnography trace spikes, we feel a strong carotid pulse, we have ROSC. This takes us to Part D, post-resuscitation care.
And this is where the patient is truly saved or lost. Just because the heart is beating again doesn't mean the brain is okay. The next few hours are critical.
So what are the immediate priorities the second you confirm ROSC?
You go right back to your ABC structure. A, secure the airway. If you haven't intubated yet, now is the time to do it in a controlled way.
Okay. B for breathing.
Optimize oxygenation. But this is a key point for the exams. We are no longer blasting patients with 100% oxygen.
What's the target SpO2?
94% to 98%.
Not 100%. Why not?
No, we now know that hyperoxia is harmful. We used to think more oxygen is always better, but now we know that excessively high levels of oxygen cause oxidative stress. It creates oxygen-free radicals that worsen the reperfusion injury, especially in the brain. So once you have stable sats, you titrate the FiO2 down.
That's a huge paradigm shift. What about C for circulation?
Hemodynamic stability. Your target is a systolic blood pressure greater than 100 mmHg or a MAP above 65. The brain has just been through a major ischemic insult. It needs good pressure to get reperfused.
And this might require vasopressors or inotropes.
Very often, yes. The heart is stunned after an arrest. You'll likely need a noradrenaline or dobutamine infusion to support the blood pressure.
Now, Miller talks about this concept of post-cardiac arrest syndrome. What does that encompass?
It's essentially a sepsis-like state. The whole body has been through this massive ischemia reperfusion event. So you have brain injury, you have myocardial dysfunction or stunning, and you have a systemic inflammatory response.
And to protect the brain from this secondary injury, we use TTM, targeted temperature management.
Correct. It used to be called therapeutic hypothermia. The goal is to actively cool the patient and maintain their core body temperature between 32 and 36 degrees Celsius for at least 24 hours.
Who is the ideal candidate for TTM?
Any comatose adult patient who achieves ROSC after an arrest. It was originally studied most in VFTVT arrests, but the benefit is now thought to extend to all rhythms.
And how does it work? Why does being cold help the brain?
It slows down the brain's metabolic rate. It reduces the cerebral metabolic demand for oxygen, which gives the stunned brain cells time to recover. It also reduces cerebral edema and suppresses a lot of the neuroinflammatory chemical cascades that cause secondary damage. It is one of the only interventions we have that is proven to improve neurological outcomes.
And of course, while all this is happening, you're desperately trying to find out why the patient arrested in the first place.
Immediately, get a 12-lead ECG.
Looking for a STEMI.
Right. If you see ST elevation, that patient might need to bypass the ICU and go straight to the cath lab for an urgent angiogram. You have to open the blocked coronary artery.
This leads us perfectly into Part E, special situations. The standard algorithm works for most people, but sometimes there's a specific reversible cause that you have to fix. The famous H's and T's.
You need to be able to recite these under pressure in your Viva. You should have them memorized.
Let's run through them. The H's first.
Okay. The H's: hypovolemia, hypoxia, hydrogen ion, which means acidosis, hyperkalemia, and hypothermia.
And the T's.
The T's: tension pneumothorax, tamponade, the cardiac kind, toxins, as in a drug overdose, thrombosis, which could be a pulmonary embolism, and the other thrombosis, which is a coronary event, a heart attack.
So the expert anesthesiologist is mentally scanning this list while running the code.
Constantly. You're looking for clues. Is the abdomen distended and hard? Maybe it's hypovolemia from internal bleeding. Are the neck veins bulging and is one side of the chest not moving? Tension pneumothorax.
And you can't just treat with drugs. You have to treat the cause.
Exactly. If the patient has a tension pneumothorax, No amount of adrenaline in the world will save them. You need to stick a big needle in their chest and decompress it.
Let's talk about a particularly high-stakes, terrifying scenario. Pregnancy.
It is. You have two patients, and the physiology is completely different. The key here is the gravid uterus. After about 20 weeks of gestation, that uterus is big enough to compress the inferior vena cava and the aorta when the mother is lying flat on her back.
Aortocaval compression.
Exactly. It completely obstructs venous return to the heart.
So standard CPR on a supine pregnant patient won't work.
It will be almost completely ineffective. You cannot generate any flow if the tank is empty. The single most important modification is left lateral uterine displacement. You must assign one person whose only job is to get on the patient's right side and physically forcefully push the uterus over to the patient's left.
And what if that fails? What if you're still not getting ROSC?
Then you have to move to a perimortem cesarean section, or what we now call a resuscitative hysterotomy.
And there's a very specific timing rule for this, isn't there?
There is. It's the 4-minute rule. If you have not achieved ROSC within 4 minutes of the mother's arrest, you need to start the C-section. The goal is to have the baby delivered by minute 5.
Is the primary goal of this procedure to save the baby?
This is a common and critical misconception. Primarily, it is to save the mother. By emptying the uterus, you immediately relieve the aortocaval compression. Venous return is restored to the mother's heart, and suddenly your CPR becomes effective again. Saving the baby is a wonderful hoped-for bonus, but the procedure itself is a maternal resuscitation technique.
That is a powerful and important concept to get right. Finally, in special situations, let's talk about anesthesia-related arrests in the OT. We're the ones giving the drugs, so sometimes we are the cause of the problem.
It happens. If a patient arrests on the operating table, your differential diagnosis is different. You have to think. Overdose of anesthetic, a high spinal block, profound hypoxemia from an airway issue, or an intense vagal reflex from surgical stimulation.
And the management, what's the very first thing you do?
First thing, turn off all the volatile agents. Stop the propofol infusion. These drugs are all cardiac depressants and vasodilators. You do not want them on board during an arrest. You switch the ventilator to deliver 100% oxygen immediately.
Okay, that covers a lot of ground. Let's try and wrap this all up with Part F comparison and exam integration. How do we synthesize all this information for the examiner?
If you're asked in a Vivo or a short note to compare BLS versus ALS, you should think in categories to structure your answer.
Okay, like what?
Like personnel. BLS can be done by laypeople or a single healthcare provider. ALS is a multidisciplinary team sport.
Good one. Next.
Equipment. BLS is just your hands, maybe a barrier device, and an AED. ALS involves an advanced monitor defibrillator, airway adjuncts, IV or IO access, and a whole crash cart of drugs.
Right.
And finally, complexity or goal. The goal of BLS is simply to maintain perfusion to the brain and heart. The goal of ALS is definitive treatment, restarting the MART, stabilizing the patient, and treating the root cause.
That's a great way to frame it. Now let's just revisit those common Viva traps one last time just to hammer them home.
Good idea.
Trap number 1. When do you check the pulse after delivering a shock?
The answer is, you don't. You resume high-quality CPR immediately for 2 minutes.
Trap number 2. You see the patient taking slow, gasping breaths. Is this a sign of life?
The answer is, no, it is a sign of cardiac arrest. You treat it as an arrest and start CPR.
Trap number 3. Your patient is in asystole. What energy level do you select for the shock?
The answer is, you never shock asystole. The treatment is CPR and adrenaline only. Shocks are for VF and PVT.
And for the theory paper, any final tips on presentation?
Draw diagrams. Please draw diagrams. Draw the ALS algorithm flowchart. It takes up a good chunk of space, it saves you writing time, and it instantly shows the examiner that you know the structure of care.
What else?
Draw a capnography trace, show the flat line during arrest, the low square waves during CPR, and then that sudden beautiful surge when ROSC occurs. Visuals get you marks.
So if we had to boil this entire deep dive down to the take-home bullet points for the exam.
Okay, 5 key points. 1. High-quality CPR is the absolute foundation of everything. Push hard, push fast, allow full recoil.
2.
Minimize interruptions and compressions to an absolute minimum. The compression fraction is king. Early defibrillation is the single most important intervention for VF and pulseless VT.
4.
Always be thinking about and searching for the reversible causes, the H's and T's.
And number 5.
Post-resuscitation care, especially targeted temperature management and hemodynamic optimization, is what determines if your patient not only survives but walks out of the hospital neurologically intact.
This has been a massive, massive download of information. We've covered physiology, pharmacology, the algorithms, and exam strategy.
It's a lot, but it's arguably the most important thing we do. The anesthesiologist is the leader in the code. Mastering these algorithms is our fundamental responsibility to our patients.
Well, we hope this simulated coaching session helps you crush that Gujarat University exam, or frankly, any exam you're taking anywhere. Go practice the algorithms, not just in your head, but physically, mentally walk through them.
And remember, in the exam and in real life, don't panic. Just follow the algorithm. It's there to guide you through the chaos.
Thanks for listening to the deep dive. Good luck.